Okay, I'm sorry that we're getting such a late start. I'm Herbert MELTZER from Vanderbilt University, and I'm both the moderator and the speaker. And as we have such a small group, be happy we could do this informally as I go through it. And if you have any questions, please feel free to interrupt. And I'll try to either answer them then, or if it's something I'm going to cover later on, I'll mention that. As I've said in a couple of the other talks I've given, I do a lot of work with pharmaceutical companies because I'm constantly trying to get access to the newest drugs, and both for preclinical and clinical work. And if you're going to do that, that means you have to be talking to some of these major pharmaceutical companies. I'm going to try to cover my view of treatment-resistant schizophrenia and really focus down on a subgroup of them. The one that I'm actually beginning is a major NIMH study that I'll tell you about, National Institute of Mental Health, and talk about its potential etiology and treatment, but particularly focusing on some of my views on how to treat them and some recent work that we've been doing that may dispel the idea, or at least challenges the idea, that high dose of that clozapine is the only treatment for treatment-resistant schizophrenia. This is a slide at virtually every lecture I give, and it's in this context I'm using it to let you know that although I'm quite aware that all these components of schizophrenia, positive, negative symptoms, cognition, mood symptoms, may be resistant to treatment, that because as I've explained in an earlier talk, these are very independent dimensions, it's possible for a patient to be resistant on all these dimensions or just one or more of them. So, for example, the so-called negative symptom schizophrenia or deficit schizophrenia would have persistent negative symptoms, but not obviously persistent positive symptoms. And the area that I focused on, because it was the way we could begin to work with clozapine back in the 80s when it was considered such a toxic agent, was that the FDA permitted us only to work with people who were considered non-responsive by the criteria of that generation, namely the people with severe positive symptoms. There was so little recognition back in the 80s of the importance of negative symptoms and cognition to outcome that the definition that the FDA was comfortable with and that I began to work on was on the focus on positive symptoms, but also included in that, which was the idea that they would also have poor social and work function. Today, that goes against the view that social and work function are more dependent on cognitive impairment. And we do in fact see many people with high positive symptoms who have pretty good work function. And by my definition, and what I'm going to be using through this talk, those people would be treatment resistant. Sounds strange because, again, many people, including me, believe the ultimate goal is to get people to function, and yet I'm telling you, let's think about these people as treatment resistant simply because they have high positive symptoms. Now, this talk, although it's around management, is going to have a lot more of a biological flavor to it. And so, but right at the beginning, I want to say there could be many reasons why people have a poor response that have only little to do with their core biology. The number one, obviously, is their poor adherence. In the United States, most estimates show that about, if you use oral medication, no more than 50% of people, and probably a lot less, are no longer following the prescriptions of their physicians within a month to 3 months of discharge from hospital. That's why for many of the outpatients that I work with right now, I use long-acting injectable medications. Just talking that here in Turkey it might be a lot better and you don't have such a need for a long-acting medication. But in the United States, given the nature of our mental health system, oral medication is really an unreliable way to treat a patient. And you'll see where I'm going right now in my research on managing treatment resistance. It is to focus on long-acting injectable medications to help them. So that's at the top of the list why somebody might appear to be a poor responder. Absolutely you have to check whether they're in fact taking the medications. But from the point of view of function, at least, some of these very critical issues that are in the psychosocial range become very important. Even people who have good control of the psychosis, if they're in the treatment plan, one doesn't address issues of alliance with the patient, the stress that they're living, the living environment, the substance abuse, and the conflicts within the families that used to be called expressed emotion. Those are things that are very relevant for all of us as clinicians, but they don't speak to this, what I'm going to try to talk about as a unique genetic subgroup of schizophrenics. So if we go back to the 1980s when John Kane and I and others at Sandoz were trying to get approval from the FDA to study clozapine, the agreed upon definition of treatment resistance was persistent, moderate to severe positive symptoms after at least 3 trials. Over the years, that number has reduced to 2, and I'm going to talk about reducing it even further in a moment. And the second criteria with the FDA, as I said, which may have been really spurious or limited this group of patients too narrowly, was poor social and work function. So do we need 2 trials? I'm going to address that first. And how long should those trials last? Okay. Before getting into that, let me say, when I approach this, and this number, you see this quoted all the time, and it's really not a hard and fast number. It's not as well as established. It may be a lot higher than this number, but the original idea that we used in the 80s came from the first generation of studies. That's a true use of the word first generation now, of the typical antipsychotics in the U.S. state hospitals, people who are absolutely virgin to antipsychotic drugs. And in the VA system, Jonathan Cole pulled all this literature together, and basically it was maintained in all the clinical trials that pursued with the typical antipsychotics, and it still seems to hold with the first generation, with the first round of studies of the atypicals, is after an adequate 4 to 6 week trial at a standard dose, let's think about 10 milligrams, 5 to 10 milligrams of haloperidol, or up to 6 milligrams of risperidone per day, 70% of those patients will have mild or less than mild positive symptoms, and 30% will have at least moderate to severe suspiciousness, paranoid delusions, auditory hallucinations, but not conceptual disorganization. Let me tell you something that we have stumbled on, rediscovered through my genetic research, that one of the core positive symptoms in the BPRS, the so-called core psychosis, which consists of conceptual disorganization, suspiciousness, disorganized thinking, which is, when you read the text, it's really forms of delusions other than pure paranoid, and hallucinations. And it turns out, we saw it first in our genetic predictors of these items, that the conceptual disorganization in that is not a positive symptom. It really tightly correlates with cognitive dysfunction, could be used as a poor man's measure of cognitive dysfunction. So it's those other three items that are the core positive symptoms. And what this literature is saying is 30% of schizophrenics, even first episode patients, are going to show, well, maybe not first episode, that's another part of the story. 15% of first episode patients, 30% of more chronic patients are going to be having moderate to severe positive symptoms. So what are the causes of that? Well, it could be a pharmacokinetic factor. It could be issues of poor absorption of the drugs. It could be rapid metabolism of the drug. But these are not the reasons that are driving what I'm talking about. Those are things that you could possibly deal with by changing the route of administration, by upping the dose of a typical antipsychotic, whatever. But there's no evidence that the people that I'm calling treatment resistant are not responding for those reasons. That was explored years ago by increasing the doses of typical antipsychotics, and nobody got any better when the doses went above 10 milligrams of haloperidol. To show that this also applies for the atypicals, when you're not treatment resistant, Bruce Kynan at Lilly did a study, which we've just published, comparing 10, 20, and 40 of olanzapine in non-treatment resistant schizophrenics, expecting, the prediction was that there would be a dose response and the 20 to 40 would be superior to the 10, and there was absolutely no dose response. 10 milligram dose was fully effective in non-treatment resistant schizophrenic patients. And the only thing you got out of the 20 and 40 were increased side effects. So this is a critical difference between the treatment resistant and the non-treatment resistant patient, that, yeah, there is a dose response, say, for olanzapine between 1 and 10, but it's not between 1 and 20, or 10 and 20, and 20 and 30 in that subgroup of patients. So there has to be some kind of pharmacodynamic factors that would cause a subgroup of patients not to respond. And what are those things? It has to be some interaction between the mechanism of action of that drug and host factors, which are either they're inherited, genetic, or can be modified, the so-called epigenetic factors that can occur in utero or post birth and lead to modifications of DNA. And these are the things that interest me at the point in terms of who's treatment resistant. So this whole line of research, as I mentioned when I spoke yesterday or 2 days ago now about the history of clozapine, really came into focus because of clozapine, those studies in the beginning in 1987, 88. And when we found that clozapine worked, it became part of the indication for clozapine, that the drug should only be used, at least in the United States, on the treatment-resistant patient or people who were intolerant, okay, who were very vulnerable to get EPS in particular. And as I showed and talked about in some detail, we found in that 1988 study that only 5% of the treatment-resistant patients responded to chlorpromazine, even though they had failed to respond to haloperidol. Whether that's the response criteria were not that rigorous in the sense that they just had to have at least a 20%. And at 6 weeks, we found a 30% of the treatment resistant. So let's talk about that again. Out of every 100 patients in the chronic group having an acute exacerbation, 30 are going to be treatment resistant, and about a third of those, 10%, that's all, at the end of 6 weeks are going to have no more than mild or moderate symptoms and some improvement in overall psychopathology so that the BPRS scores came down to a low level. As I mentioned yesterday, and this became crucial, but I didn't fully appreciate it until some years later, when we continued the drug treatment with clozapine, another equal number of the group of treatment-resistant patients, by the criteria of moderate to severe positive symptoms, then had a decrease in positive symptoms. So, should have put another slide in here, but say you can continue to treat with typical neuroleptics, and you're not going to go beyond the 70%. Maybe a few will respond, like the chlorpromazine in the study 30, but whereas in an atypical antipsychotic with clozapine, if you continue to treat with clozapine for up to 6 months, you're going to get more response. And of course, we followed that out further in the people who didn't respond, I'm not showing that there was no further increment. This is those people that are responding. They really plateaued. Something was happening for those people between 6 weeks and 6 months in terms of both BPRS. These are on different scales, and we're talking about percentages of improvement, but there's a decrease here in BPRS total. I'm not sure I've got these color-coded correctly, but you get the general idea that we peaked here at about 6 months in terms of outcome. Okay. So we are now focusing a lot more than I did at the time on what's the mechanism of this delayed response. At the time, I published a paper using CT that showed that we could discriminate between the people who responded early and who responded late in terms of what we'd now consider gray matter problems, that they had more atrophy, increased ventricular enlargements. There was some suggestion that at the time that they were more chronic, but I'll show you another basis for what we now have found to be why some respond early, some respond late. We did notice that when they did respond, these late responders, that they did as well as the early responders, and that clearly, this is a mistake down here, that the duration of a clozapine trial should be 6 months, not 6 weeks, as it shows there. Okay. Let's see, where are we? No, we're going, okay. So there have been many replications of the clozapine effect. Most recent meta-analysis by Luke and Davis confirm that clozapine is superior in the treatment-resistant patients. I don't think anybody really challenges, and certainly I don't, that this is the one proven treatment for treatment-resistant patients. And when you identify that failure to respond, certainly the patient should be informed that evidence-based medicine would suggest that clozapine is worth a trial despite the risk of agranulocytosis. But this has been, and Dr. Asser talked about it yesterday, both clinicians and patients have certainly more often rejected clozapine than they should, and something we really need to work with both groups to think about using it. There are now two groups, one Israeli group, one American group, that have proposed, in fact there's a commercially available genetic test for agranulocytosis, the the Bayesian analysis of whether it is sufficiently robust to justify the expense and will really tell you who's at risk and shouldn't get clozapine, isn't really strong enough in my view yet. So, but it's quite possible that we're going to have a test, and that would change dramatically the risk-benefit of using clozapine. So let me speak now to when we should start it. Should we start it after 2 trials, or should it be after 1 trial? And I'm going to show you some data that suggests, it's just some of our data, but it's certainly consistent with the rest of the data that I'm aware of, that is significant, that 1 trial may well be sufficient. And what is that? Well, I talked yesterday about the mechanism of action of the atypicals as a serotonin dopamine antagonist, and so we've been dissecting the components of that in a very simple way. For example, using this drug pimavanserin ACP 103 with a sub-effective dose of risperidone, 2 milligrams, in chronic schizophrenic patients, not treatment resistant. This is just to establish the time of what's going to happen in a not treatment resistant patient, and with a single trial. And we've compared that with risperidone alone, 2 milligrams, and placebo, and risperidone 6 milligrams plus placebo. I'm not going to report on the haloperidol data. That'll be in a final publication that's coming out. It was a 6-week trial. It was done in the Brazil and United States, multi-center, double-blind, randomized trial. And this is the bottom line. These are now percent responders after 6 weeks of treatment. And what you see here is, let's just look at the 2 milligram dose of risperidone alone, deliberately chosen to be sub-effective, but in fact, this is just around in the duration of the trial. Some of the people in this, we didn't have a placebo in this study, but we had some response at 1 week, some at 2 weeks, and no further benefit between 2 and 6 weeks. So that, now let's look at the 6 milligram risperidone dose. They didn't separate between 2 and 6 at week 1. They didn't separate between week 1 and 2, but between week 3 and 6, they did separate, and there was no further improvement. So this speaks rather more to the issue. I really meant to frame it in the context of how long do we need a trial? Does it have to be 6 weeks, or could it be sooner? Some people are saying 1 and 2 weeks are sufficient. Let me go back to that. This would suggest that 1 and 2 weeks are insufficient, even when you take a dose of what is usually an adequate dose of risperidone, 6 milligrams. We're still improving between week 2 and 3, but then we plateau. What happened with the 2 milligram dose of risperidone when we added back to it enough 5-HT2A antagonism? And there you see that was the most rapidly effective treatment. But even there, we still didn't go beyond 60% response rate in these particular patients. I wanted to use this concept also to reaffirm the importance of 5-HT2 antagonism to a drug like risperidone and clozapine. Okay. So why wouldn't people respond to an adequate, and the haloperidol dose, haloperidol data looks very much like the 6 milligram risperidone data. So although it wouldn't be surprising to Joe McAvoy, who talked about the threshold, the neuroleptic threshold with haloperidol being around 2 to 5 milligrams, that 2 milligrams in this clinical trial, which is about 100 patients per group, the 2 milligram dose of risperidone was as good as the 6 milligram dose of 2 milligram dose of haloperidol was as good as the 6 milligram dose of risperidone. So what could be going on here? Well, we know that drugs like haloperidol and to some extent risperidone are working by D2 receptor blockade. to diminish the response, and that clearly that's not adequate for the 30 to 40% of the people who were in an acute psychotic exacerbation that didn't respond in this particular clinical trial, which is just one trial, but it's very representative of all the other data out there. As I said, our findings with the pimavanserin suggest that the 5-HT2A receptor has to be blocked. And then, so the treatment-resistant patients, we might assume, have mutations in the 5-HT2A receptor, or other things that modulate the 5-HT2A receptor that make them unresponsive to either 6 milligrams of risperidone or to the 2 milligrams plus pimavanserin. So we have at least 2 genes here. Now, does this make sense? Yes. We have, in fact, in our treatment-resistant patients, found a much higher rate of certain mutations in both the dopamine and the serotonin system that discriminate between the treatment-resistant patients and the non-treatment-resistant patients. So the pharmacology and the genetics say those people who are treatment-resistant are genetically different, and it has something to do with the effects on the dopamine and the serotonin system. And together with Brian Roth at UNC, we're developing groups of mice that have altered serotonergic function, and lo and behold, they are unresponsive to clozapine. Okay, so all that's coming to the state that this could be a truly unique subgroup of people with altered dopaminergic and serotonergic. I mean, it's surprising in an extent. When I went through, so far I've gone through about 25 genes, looking for genes that discriminate between treatment-resistant and non-treatment resistant. And the ones that doing it so far are all related to dopamine and serotonin. And things that we've explored that look like good candidate genes for this kind of thing that are not related to serotonin don't discriminate. And I'm not saying they're not involved in schizophrenia, but it is no accident that a drug like clozapine, and the drugs that the genetic work that I've done in that direction has been all based on the pharmacology of clozapine, not all, but largely. And of the pharmacology of clozapine that we've looked at, it turns out it's the serotonin dopamine that seems to be most predictive. Okay. So the biological basis for treatment resistance in a specific patient, just think about this conceptually, it could be related to the biological basis for response in the non-treatment resistant, namely D2 dopamine excessive blockade, excessive dopaminergic stimulation. You got to block that in some way. You got to block the synthesis of dopamine. When you can't do those things, those people are going to be treatment resistant. Or it could be, as I said before, but probably isn't, that they just need more of that. They just need an increased dose of the D2 receptor blockade. And that doesn't seem to be the case. Does it seem to be the case that their psychosis, we call them schizophrenics, the phenotype looks the same, but do they have a totally novel kind of disease that are making them psychotic? That's possible. We don't have that yet, but it's not something that we could rule out. So you begin to try to look at if you get down to the core biology here, are there things like the way the receptors sensitize or desensitize, downregulate? As Brian Ross showed, drugs like clozapine and olanzapine, but not haloperidol, dramatically change the receptor internalization once they get blocked. They could have different changes in membrane structure. One of the genes that Dr. Roth and I have found is involved is PSD95, which is critical for the docking of the 5-HT2A receptor. Another possibility is that there's just neurodegenerative changes taking place. We saw that in the old CT scan data. David Garver has shown that the atypicals seem to restore gray matter mass more than the typical antipsychotic drugs. That's something that we're also trying to confirm at this time. So here I've mentioned this point already, that SNPs related to serotonin and dopamine receptors and their signaling systems are among the genes which discriminate treatment-resistant and non-treatment-resistant patients, and then mice with these genes knocked down don't respond to clozapine in a variety of ways. And we'll be publishing a paper on a PCP-based novel object test where we can restore, reverse, and prevent the effects of PCP with a strategy that just focuses on dopamine and serotonin. Okay, so I think we're approaching the time when we will have a biological test for the treatment-resistant patient, and that would suggest at that point, if it gets to be definitive enough, that we won't have to subject people to what's going to be a failed trial of a standard dose of a typical antipsychotic and go right to clozapine. So this is where I've come back to this because of this NIMH study that we're reasonably confident we're going to get funding for to pursue the genetics of treatment-resistant. It's the concept of what happens to the first episode patient. Are there treatment-resistant patients from the very first episode? And if you're not treatment-resistant from the first episode, do you ever become treatment-resistant? So there's numbers of studies that suggest roughly only a half of the people who are treatment-resistant, the 30% number, whether it's 25 or 45, it's in that range, that the vast majority of consecutively studied first episode patients say at the end of an adequate trial of a typical or atypical antipsychotic, 15%, 10 to 15% will be treatment resistant by the criteria I'm talking about. What does that mean? Another 15% have to become treatment resistant subsequently. And I published this back in '96 when we were looking at our treatment-resistant patients when they became treatment-resistant. We had terrific data from families, from medical records, and of the 146 treatment-resistant patients that we had these data on, we showed 55% never responded in their first episode, and another 45%. And so that totally consistent with the Robinson data, the McGlashan data, the McGorry data, that you can become treatment resistant later on. Well, our working hypothesis at this point is that these are different groups. They may share something in common, but from looking for genetic markers at this point of this, we think we have to discriminate between these two groups. So look at this. In that population, the age of onset of resistance was the age of onset of the first episode, basically. In this first episode, onset treatment resistant, it was 22 years. It was a decade later. So this second subgroup of people, we had reliable histories data that their psychosis was controlled for almost a decade on average, sometimes longer, and then they lost it, and then they came into our studies and got onto clozapine. Was there any clear difference in psychopathology? Could we discriminate these two people on the basis of history? Of actual clinical assessment? No, not in terms of total symptoms, positive symptoms, negative symptoms, disorganization, global function, and quality of life scale. That didn't predict that. Well, what did it predict? It predicted their response to clozapine at 6 weeks. There was I'm not showing you the dosage, which was the same in the two groups, but this first episode group had a much poorer response to clozapine than those with the delayed response. This is mislabeled up here. So the people who developed treatment resistant later on were our 30% who responded to clozapine in terms of positive symptoms, negative symptoms, disorganization, and also in terms of some measures of cognition. So in terms of improvement in category generation, in working memory, that's be verbal fluency, there was, not in verbal fluency, in verbal fluency, not in working memory. These two groups could be separated. Here in terms of speeded motor pursuit or attention, and in terms of executive function here, these two groups are separable. So the work we're doing right now, we're collecting a new cohort like this, and we're going to be doing a genome-wide association study and sequencing to try to get at the genetic differences between these two groups. So what it says to me is now, with the first episode schizophrenic patient who's failing to respond to adequate doses, and maybe within as little as 2 to 3 weeks of treatment, that one could consider going on to a trial with clozapine. It may be a little radical, but I'm throwing it out for discussion. And that particularly if it's a first episode patient and you start them on clozapine, then you may want to continue that trial for up to 6 months. You're going to have, if our data can be replicated in these late onset patients. So not many people, when I've started to talk about this and I ask them, do they inquire around this issue of when people became treatment resistant, it's not part of the standard assessment. And I'm suggesting that it would be. Well, David Osser and I have presented our original algorithm a couple of times at this meeting about what to do after people fail those original trials. I've modified this somewhat. I don't want to talk about that right now. I just want to present the old algorithm of going to clozapine after 1 or 2 trials and as the recommended pharmacologic treatment of the treatment-resistant patient. Dr. Osser talked about this at some length in how to use clozapine. I won't go into that again. Just the highlights are preparing the patient and the family before you start treatment with it, monotherapy up to the full dose range, measuring plasma levels, including some attention possibly to N-desmethylclozapine ratio, the psychosocial supports that you need. I'm going to skip, I'll come back to some adjunctive medication issues later, and just mentioned ECT is what I usually find most useful in the patients, that 40% of people given clozapine who don't respond to it, that to treat the psychosis, that's the most effective treatment. I won't go into the details of that. We are, and as are many, finding that formal cognitive rehabilitation programs can be very, very useful in helping people function better even when they're on clozapine. It's I think, critical to have assisted work programs and attempts to assess the cognitive impairment and try to improve it as much as you can with formal cognitive rehabilitation. So a year or so ago, so let me just tell you historically what happened. So I mentioned this briefly yesterday, that after we did the treatment-resistant study, in which the average dose of clozapine was 500 milligrams per day, I did a study in non-treatment-resistant patients and found that clozapine worked very, very well in that group to treat positive symptoms. These were acutely ill, but no better than haloperidol. and we found the average dose in those patients was around 200, 250 milligrams a day, roughly half the treatment-resistant patients, and we didn't find any benefits beyond 6 weeks. And I didn't pursue that very much until I began in the mid-90s to work with melphalan, another 5-HT2A/D2 drug that's available. Is it available in Turkey? It's called Buranol in Europe. It's a Lundbeck compound. You don't have it here in Turkey? Okay. It's a fascinating drug. It was discovered in Sweden in the 1980s. The first clinical trials were at the Karolinska Institute. It was compared with Navain. It was equally effective to Navain in doses of around 150 milligrams a day, but it did not produce extrapyramidal side effects, and it didn't produce prolactin elevations. And for that reason, it was considered a weak antipsychotic. If a drug didn't produce extrapyramidal side effects in that era, it was considered ineffective, and it was relegated to use as for agitation in the elderly. It was given to many, many elderly people and never produced any cases of tardive dyskinesia. I got involved as a consultant to the company and discovered that it was indeed a serotonin 5-HT2A/D2 antagonist. Done a lot of basic work with it where it looks just like clozapine. And to make a long story short, we did, and the data are published, trials in both open trials, not blinded trials, in non-treatment resistant and treatment resistant patients. And the data we got were just very consistent with what I've told you about clozapine. The dose in the non-treatment resistant patients is a third to a half the dose in the treatment resistant, and we got about 50 to 60% of the treatment resistant patients to respond to melphalan. So that those two sets of findings, one on clozapine, the parallel with melphalan, led me to believe that this might be a general characteristic of these 5-HT2A/D2 drugs, that at higher doses and longer periods of time, they are effective in treatment-resistant patients. So beginning in, it would be 1998 or so, I was working on the idea that olanzapine, which is the closest pharmacologically to clozapine, might show the same thing. And there were a number of anecdotal papers in the literature suggesting that when you went beyond the standard 15 to 20 milligram dose of olanzapine in treatment-resistant patients, that they were responding. I think most people took that with a grain of salt because, with one exception, one very important exception, it never really became standard to use high-dose olanzapine in treatment-resistant patients. So I was able to get funding from Eli Lilly for a double-blind randomized trial, which proved in the United States very hard to get subjects to consent to. The design included 9 capsules a day with clozapine in 100 milligrams per capsule, so they could get up to 900 milligrams. And the olanzapine included was 5 milligrams capsules that could get up to 45 a day. And there were identical capsules, of course, and everybody had their blood drawn, so there was no way, at least from that basis, to discriminate between the two of them. And what happened was the average dose of clozapine in these very treatment-resistant patients was between 500 and 600 milligrams a day. So the clinicians who were doing the prescribing, this was 4 centers in this trial, really ramped up the dose of clozapine to get the clinical benefits that they were looking for. 56% of them had at least of the patients had at least 500 milligrams a day of clozapine. The olanzapine prescription was again somewhat higher, between 6 and 7 pills per day, up to 30 the average was 32.7, but only at least at 6 weeks. And you can see we weren't doing that well, particularly you see it in both groups. By 6 weeks, the response, as you'll see in a moment, was so poor with both those drugs that the clinicians decided to increase the dose from a median of 400 at 6 weeks to 700 of clozapine at 6 months, and olanzapine, which they actually ramped up pretty quickly, from 30 to 40. All they knew that was they were prescribing, say, 6 pills or 8 pills a day. The number of subjects that got at least 35 milligrams of olanzapine was 71%. And here's what happens. This is published in the Journal of Clinical Psychiatry last February. These were very sick people. These are PANSS total scores over 90 to begin with, although they were all outpatients. And you can see there was very little improvement in either group at 6 weeks, consistent with the study 30. But by 6 months, we got a 20-point drop in the PANSS score, which was approximately a 30% improvement. There was clearly no group times time. There was an enormous time effect, but absolutely no difference between these high-dose olanzapine. And what I now would like everybody to consider when they prescribe clozapine is that they're prescribing high-dose clozapine if you're getting these patients up into that dose range. You see here the same thing. There was a little bit of a, I'm not going to show you all the data that's published, but there's a little bit of a difference. It wasn't significant. Again, no group times time. Very large effect size. Both drugs worked to improve positive symptoms. The same held for negative symptoms, and I can tell you the same for cognition. When we applied the Kane et al. Criteria for percent responders, we only got less than 10%. I mean, if we'd had this kind of data from the original Kane study, hard for me to explain why this group was so resistant even to clozapine early, but they surely were. It was a little bit better response to olanzapine. These numbers are not significantly different. But you can see the dramatic difference between 6 weeks and 6 months in this particular trial. Now I'm going to probably spend more time than I should, but it's to show you that the Katie data on the story are entirely consistent with what I've just told you. So for reasons that are unclear, Jeff Lieberman says he had nothing to do with it, and Eli Lilly say they have nothing to do with it. So I don't know who else had something to do with it. They permitted olanzapine to be used at 30 milligrams a day, whereas the top dose of risperidone was 6 milligrams. The top dose of, and these are supposedly in non-treatment resistant patients. The top dose of quetiapine was, I believe, 800 milligrams. And the top dose of ziprasidone was 160 milligrams. So the average modal dose of olanzapine, which, as you know, turned out to be the most effective treatment, was over 20 milligrams, and 40% of the patients had 30 milligrams, which, now at the time they did this, they didn't have the data from the Kynan study that I mentioned to you, but that Kynan study clearly showed that all you need for a non-treatment resistant patient is 10 milligrams a day. So where I'm going with this is that why was olanzapine superior in terms of time to discontinuation for lack of efficacy? This is olanzapine. Now notice what happened. There was no discrimination until 3 months. Okay? What have I been saying about the time for high-dose olanzapine to work is between 6 weeks and 6 months. So what I'm proposing, and I've written about this, is that this is not due to anything inherently superior to olanzapine, but to the fact that there were, and I've published on my calculation that about 35% of the people in the Katie study were treatment resistant. Okay. The phase 2 study of Katie, where these treatment resistant patients were supposed to go in and to a trial that would compare clozapine to olanzapine and quetiapine, and olanzapine, quetiapine, and risperidone, has been written up to indicate that clozapine was superior to all the rest of them, but in fact, if you read the paper carefully, it did not discriminate from olanzapine, this 30 milligram dose, in terms of changes in PANSS total and positive. When you look at the time to discontinuation, and again, this is the clozapine in that group, this is the olanzapine. By the end of the trial, these two drugs also did not discriminate in terms of any cause, and the lack of efficacy reason for discontinuation did discriminate, but the people that went into this trial knew that they could get clozapine, which was given on an open basis. The olanzapine was given on a blinded basis, and I think they just simply discontinued in order to get ultimately to get onto clozapine. So I don't think that study, if you read it carefully and you think about the methodological problems with it, establishes that clozapine is superior to olanzapine in the treatment-resistant patient. Rather, I think it's consistent with what I've just told you. So this is a modification. It's not posted on the website of IPAP, but I would, and I'm not, this is out of label, and all I can tell you is how I see it, that this is a modification in which high-dose olanzapine would get in there. Well, this chart is completely the work of David Osser with some participation from, and certainly approval from me, and I have it here just to show you, what you well know. There's an enormous metabolic problem with clozapine. There's an enormous metabolic problem with olanzapine. Far exceeds what the other groups are. So we would like not to have to use either of these two drugs, especially at these high doses. So that leads to potentially using one of the other 5-HT2A/D2 drugs. And I can just tell you, I'm in the midst of a Janssen-funded study, randomized, blinded study of high-dose, long-acting risperidone, in comparing it with standard doses. So we're comparing 100 milligrams every 2 weeks of risperidone consta with 50 milligrams. And it'll probably take us another year and a half to complete it all. But it certainly will provide an initial test of the idea that this is consistent with a serotonin 2A/D2 mechanism. Now, is it also possible that it would work with ziprasidone and quetiapine? There are anecdotal case reports in the literature, some series, suggesting that quetiapine in doses up to 2 grams a day may be effective. Less data with ziprasidone, but there's some that these drugs have superior side effect profiles to clozapine, not especially quetiapine, but certainly Geodon or ziprasidone or Zeldox, I guess it's called in Europe. But we really need a lot more data, and so I'm not proposing that you include this in your management of treatment-resistant patients, but just be aware that there is this possibility. In terms of pharmacologic enhancement, I presented yesterday that we couldn't enhance clozapine partial response with risperidone or haloperidol. The one drug that there seems to be some fairly consistent literature, this is one of the original reports, that lamotrigine augmentation. I haven't any real experience with it. Maybe David also will comment on it, but it's something I think worth trying if you want to if you have a persistently psychotic patient on high doses of clozapine and don't want to go to ECT. What's the future for working on treatment-resistant? Well, if we can get this genetic signature for schizophrenia and for treatment-resistant, clearly intervening during the prodrome, minimizing the duration of untreated psychosis, maybe starting clozapine much earlier in the course of illness. I remember an anecdotal story when I presented a series of lectures in South Africa. A woman got up from the floor. She was the president of the family members with schizophrenia in all of South Africa, and she told me about her 3 sons. And the oldest, when he became psychotic, it took years to get on clozapine, but then he did reasonably well. The second son, when he became psychotic, he got started on clozapine after about 2 years. And the third son got started on clozapine within the first weeks of becoming psychotic. And she said that he was doing just fine, and so was urging the earlier start. And I am basically recommending that also. Okay. No, I'm going in the wrong direction. So, oops. The final slide was simply to sum up here. Can we go back to the last one? Just summing up that the management of treatment-resistant schizophrenia still focuses on clozapine and psychosocial treatment. The possibility that other atypical drugs. You're going to go. Okay. You went right past it. Here it is. Anyway, why don't I stop there and see if there are any questions, comments?